Okay, now it's 3:03. Okay. Dr. Nasir, are you ready yet?
Yes, Prof. Yes.
Yeah. Would you like to share your presentation?
Okay, thank you, Prof. Okay, Assalamualaikum and very good afternoon to everybody. Thank you for giving us the opportunity to share one of our interesting case here in Queen Elizabeth Hospital. Okay, basically, after this case presentation, we will have a few PDF, sort of like quiz after this first case. Okay, Mr. SD is a 53 years old gentleman from Tawau. He was diagnosed with CML in 2021 when he presented with generalized body weakness, loss of weight, abdominal distension, hepatosplenomegaly, and also leukocytosis and thrombocytosis. During that time, the BCR-ABL was detected, and he was treated with TKI. So this year, in August, he presented with fever and lethargy for 1 week. However, he has no other symptom, such as skin lesion, GI symptom, and other symptoms. He had hepatosplenomegaly, and during that time, the HB was severely low, severe anemia with HB of 6.9, a low platelet 39, and also leukocytosis. White cell count was 286, but other investigation was normal. So PDF was sent to Hospital Tawau, and these are the PDF. Okay. Basically, leukocytosis with predominantly blood cells, and most of the blood cells showing medium size fine chromatin with metachromatic granules. Can you appreciate the granules?
You have a larger magnification. I think I can see lah, but I'm not sure other people can see. Okay, very good, very good. I can see the metachromatic granules. Many of them all. Is it almost all the cells have got metachromatic granules?
There are cells like this, which doesn't show metachromatic granules.
Yeah.
But most of the cells are showing metachromatic granules.
The question is whether these cells with metachromatic granules are actually has an immature nucleus or not, or is it actually is a matured nucleus?
If you see the nucleus, they are fine chromatin, inconspicuous nucleoli, anti-cytoplasm. They are black looking.
I think it's important to know because we wonder whether these cells are actually matured cell or immature cells. Maybe the
Normal,
trephine can see better.
unfortunately, the best picture we can see the metachromatic granules is in this PDF.
Oh, okay. Yeah.
But
Yeah,
the
yeah.
Miro and also Trephine, after this, you can see
I
the
understand.
granules are not apparent.
Understand. But the main question I'm going to ask is actually when you see those cells with metachromatic granules, the question is whether they are actually primitive cells or actually they are matured cells. Yeah.
Here also you can see four myeloblasts, which
yeah. No
does
granules.
not have no granules.
Yes, that's right.
Some of the cells are binucleated like this. Interestingly, with a lot of mast cells, if I can say mast cell, patient does not have skin lesion, GI symptom or respiratory symptoms, no hypotensive episode. So only lethargy, fever, hepatosplenomegaly. So they send peripheral blood IPT, but I want to show the marrow first.
Okay.
So the marrow come after the peripheral blood IPT. Okay, this is the bone marrow done in August. The fragments are hypocellular. Limited fragments available. But the cell trail shows mainly blood cells. Normal hematopoietic cells are markedly reduced. In bone marrow spirit, the metachromatic granules are not prominent like in the peripheral blood film, but they are cells with granules, but you have to scrutinize the pathology like this.
Yeah, most likely they are. They may be, some of them may be actually spindle shaped. Huh?
Yeah. Some are binucleated like this. To assess dysplasia in this marrow, quite difficult because the normal hematopoietic cells are reduced. This probably the small hypolobated megakaryocyte.
Yeah. There's some spindle-shaped cells. Huh?
Yes.
Yeah, there are a few there also, like having metachromatic granules. Yeah. I think it's separate, obviously a separate populations of cells, independent of the blast cells that you just now indicated.
Yeah. So these are the picture of PDF, blast abnormal cell with metachromatic granules. Okay, this is peripheral blood immunophenotyping. For acute leukemia orientation tube, you can see the normal population CD45 intermediate, low to moderate cell scatter. They are negative for B cell markers, CD19 and 79A, and also T cell markers cytoplasmic and surface CD3. Small population of the blast, CD34 positive, but most of them are CD34 negative and MPO negative. So because of blastic morphology and negative for B and T markers, proceed with AML tubes. So this is AML tube 1. You can see the red population, the normal cells, they are CD117 bright with heterogeneous HLA-DR. CD13 are positive, myeloid marker. CD16 negative, 11B heterogeneous. CD10 negative. Okay, I say negative because for APCH7, when we put a blank tube like this, it has autofluorescence. So basically, the pick the partial positivity because of the autofluorescence, I think, because of the metachromatic granules. The second tube, the monotubes, CD64 negative. The CD14 similar with the CD10 because of APCH7. Actually, it is negative. CD300E also negative. So for monomarker, negative this case. Third tube, CD33 is positive compared with the residual times. CD35 105 negative. CD71 is a false positive because of the APCH7. CD36 negative. So I want to prove that this is mast cell, so we put additional tube to assess CD25, 1, 2, 3. So CD25 shows heterogeneous expression, CD1 to 3 positive. And these are the basophils expressing CD203C and 123, but the basophils are CD17 negative compared to the mast cells. The mast cells are CD117 bright. Here you can see also the CD34 positive population. They are HLA-DR positive, but 17 negative. These are the myeloblasts. So here we reported as presence of 80% normal mast cells expressing CD117, HLA-DR heterogeneous 13, 33, 123, CD200, 203C, and CD25. So next we look at the tryptophan biopsy. Okay, the cellularity is hypercellular with adequate mirror space. And there are occasional megakaryocytes. This one. And we can see the normal hematopoietic cells are reduced, replaced by these abnormal cells. We can see some of them showing eosinophilic granules. Occasional plasma cells. The neutrophils are there, but markedly reduced. Okay, if you want to visualize the mast cells, we can use GEMSA to
Yeah,
see
DIMSA
the
will be very
metachromatic
good.
granule.
Yeah, because the H&E cannot see them so well.
Yeah. But for abnormal mast cells,
This one is,
neoplastic mast cells, they can have
yeah, but the blue stain is
negative GEMSA.
too strong. Yeah.
For this case, we cannot demonstrate the metachromatic granule using the GEMSA.
Yeah, because
So
you need to dilute a bit when then the stain is too strong, cannot see. The question now is to look at the TREFI, whether you see one single population or actually two different populations. In other words, in the blood film, we actually see myeloblasts and also cells, blast-like ones, not sure whether it's matured. Blast-like cell with metachromatic granules. So the question is, we do see this, double population in the bone marrow or not?
Okay, in the IPT, the myeloblast is MPO negative, so a bit difficult to visualize, but we can see by CD17 because mast cell has a stronger expression of CD17 in tryptophan. You can see the stronger 17 is actually the mast cells. They are in aggregates, but in the background you can still see the weaker CD17. That could be the myeloblast.
Okay.
We also did tryptase. So you can see weak positivity for tryptase. And CD25.
Your tryptase, your control is working well lah.
Yeah.
Because it's quite surprised the activity is only, not really that strong, whereas your CD117 stain is actually very strong.
This is control for tryptase.
Oh, staining for what cells? Mast cells?
Yeah, mast cells.
Okay. Yeah. So it's interesting that your mast cell, staining doesn't correlate with your observation with CD117. So sorry, what is the next one?
This is CD25.
25.
CD25 will be positive in neoplastic mast cells,
Okay.
but negative in normal mast cells.
Oh, okay. Yeah. All right.
But CD2 and CD30 we did also negative for this case.
Mm.
In abnormal mast cells, the CD2 and CD30 can be positive.
Okay.
This is MPO. Highly scattered MPO with loss of paratrabecular MPO positivity.
Yeah, so probably all the residual granulocytic series. Yeah, it's negative for the both type of cells, the blast cell as well as the mast cells.
This is CD34.
34, okay.
Yeah.
So which the 34 is picking up by what cells? Doesn't look like the.
So you can, you can see the endothelial cell and also residual blast cells, the myeloblasts.
Yeah. Okay, so the myeloblasts may be picking it up from weak to moderate, whereas the mast cells are not picking it up. Huh?
Yes.
Okay.
So this is these are the results from the SRM quantitative assay. You can see it goes down in April 2034, but in August the desirable kinase domain mutation F359I mutation was identified. So this can cause resistance to TKI. And serum tryptase for this patient was markedly elevated, more than 200 microgram per liter. But for secret, the 8163 mutation was not detected. Cytogenetic was sent to HTA, and the findings are complex karyotype with deletion on chromosome 4, addition of genetic material to chromosome 12, isodecentric chromosome and on chromosome 17, and also additional chromosome 8. FISH shows desirable fusion signal, loss of PP53. So the patient has complex karyotype with deletion of PP53 and desirable. So the adverse prognosis for this patient. So basically, when we had this case, the morphology looked like mast cell, but clinically, patient does not have symptom like systemic mastocytosis, but because of the immature mast cells, the histamine associated symptom was not that marked in this patient.
Okay. What is your conclusion then?
Basically, my conclusion is this patient has acute myeloid leukemia with mast cell differentiation.
Okay.
And this patient has complex karyotype, TP53 alteration. It is associated with poor prognosis.
Yeah. So the thing is that when you look at the morphology of this case, one of the things that we have to think of is whether this patient actually in the first place has systemic mastocytosis. Although the background picture is actually this patient got chronic myeloid leukemia under treatment, and then later on, obviously there are clonal changes, and then evolved to another malignancy. So the question now is that is this a patient has got a clonal evolution giving rise to from a CML to a blast transformation of acute myeloid leukemia, potentially like what Dr. Nasir say, they might be actually have mast cell differentiation, or is it actually the patient is having a systemic mastocytosis? So these are the things that we have to differentiate lah. I think that's why I was asking whether the cells which carry metachromatic granules, is it a matured nucleus or more like an immature one? But just now when you show the trifine, I think they are more like actually blast lah, because they got nucleus, Yeah. So so in other words, it's actually myeloblast with mast cell differentiation rather than a patient with systemic mastocytosis where the nucleus are more matured. Yeah. And then also the other thing, of course, like Dr. Nasir pointed out, if there is systemic mastocytosis, you will expect some symptoms of mastocytosis, which this patient don't have, right? And then also the tryptase also is not fantastically high lah. I mean, it's rare, definitely. Yeah. If you in mastocytosis, the reading will be really very, very high. Yeah. So I think I agree with you lah, Dr. Nasir. You are quite right. Actually, it's more like a CML under treatment, then after that got clonal mutation, giving rise to acute myeloid leukemia with mast cell differentiation, a mast cell differentiation or a phenotype. Yeah, of course, the karyotypic study have shown that it's a very complex karyotypes, and of course, with all those loss of TP53, etc., obviously it's going to confer very bad prognosis to this patient. Yeah. Okay, I think we totally agree with you with your diagnosis. Maybe let's find out from the audience. Have you encountered such a case? Do you all think that you all agree with Dr. Nasir? Okay, I don't see any response. I suppose we all are convinced lah by your your finding. It's indeed, a patient with mast cell differentiation, because that's very important. Because in terms of classification of this leukemic transformation, whether this patient actually all the while has got systemic mastocytosis as well, and we know that systemic mastocytosis also is associated with myelodysplasia and also like clonal transformation to myeloid leukemia, things like that. Yeah, certainly need to be properly documented. Okay, so this first case, I think Dr. Nasir have got also some quiz slides, right? Spot diagnosis for all of us. Maybe Dr. Nasir, you can share one or two.
Okay, I have only 6 slides for PDF, but only 4 I can get the history and the FDC. So we go to the first case. This is 72 years old male with underlying smear positive TB. uh, having thrombocytopenia and anemia.
So you would like the audience, some of them say they cannot see clearly. Is it possible to focus? If anybody spot anything, can offer. Either you can speak out or send a message in the chat box.
Okay. Anyone want to try to answer for diagnosis?
Maybe you enlarge a little bit lah. Oh, yes, information coming along. Can see malaria parasites. Yeah, I think it's important. It cannot just stay at malaria. See, can venture wise the species are.
Do you want to guess what is the species? Basically, in Sabah,
no sign.
yeah, most common in Sabah is knowledge.
Oh, okay.
Okay, go to the next case.
How to say that this is no sign?
How to say?
I know. By statistics,
Basically,
the most common lah.
Usually, when I see the opposite, the morphology look bizarre, and you have more than one parasite in one RBC, so most likely is molessi. For example, like this one, you can see two parasite in opposite in one RBC.
Multiple infection.
Yeah, multiple infection.
But the only thing is that falciparum also behave like that, or?
Yeah, falciparum usually the ring would be nice, very nice, and see the banana genetocytes.
The red cell size don't change, right? Is it the same? Yeah, not like Vivax. If you know the parasite, the malaria infested red cell, the red cell size will increase in the Vivax. Falciparum remain the same size now. The thing, of course, falciparum, the trophozoa, the ring trophozoa is usually very fine, but this one is very thick one, no?
Like this fancy ring form.
Do they have gametocytes? In this case, any
this one is schizon.
Oh, yeah. Okay. Yeah, normally you don't see all these schizon in the peripheral blood for falciparum. Okay, it's good.
Okay.
Right. Yep. We can, yeah, somebody also mentioned the red cell size is not increased. Of course, using current stain, you won't be able to see all the, the pigment of the red cells to help you in the diagnosis. So more like you look at the morphology of the parasite, look at the change, whether it changed the cell size, and whether the parasites are actually, a fine type or very robust type to help you to distinguish the species.
Okay, next case would be beta thal major patient. He had undergone splenectomy, admitted because of septic shock, secondary to bacteremia. So HB was severely low, 5.6, leukocytosis and thrombocytopenia. So thal major, post splenectomy, being sepsis.
The thal major already gone for splenectomy, no?
Yeah,
Gone,
gone. Already did splenectomy. Yeah.
Oh, okay. So somebody say it's malaria again.
So did you see the whole jolly body?
This is a Howard Jolly body, not malaria.
Actually, two in one lah. Malaria and
Also got
splenectomy.
malaria.
Yeah.
Oh, okay. So that's very unusual. People who got thalassemia are supposed to be protected from malaria, but people who are immunocompromised may not actually, the protection will be lost. So you won't be surprised in this case if the thalassemia major has been splenectomized, then they are also at risk of malaria invasion. So again, let's see, what species is it?
Can say multiple infection in one
Similar.
LBC.
Okay. Robust looking ring trophozoites, multiple infections. Red cells remain the same size. So same species lah.
Okay.
Okay, good.
So next case. 51 years old male presented with fever, chills, rigor, arthralgia, full oral intake for 3 days. Mild anemia with thrombocytopenia.
So fever. Is a rouleau formation, right?
Maybe this is at the thick area.
Oh, the thick area. Okay.
But this one very subtle. You have to look for it.
Okay, let's have a look. Yeah. Can go for higher magnification. Okay. Saw already. There's somebody mentioned also malaria also. Ring form seen already.
So if you're not careful, you can miss.
Yeah.
Another one.
Do you all now Sabah using other than blood film screening any other methods? Chemical methods?
Chemical methods.
Any sticks or anything?
Rapid test.
Rapid test for malaria.
Yeah. But we have blood film, PFMP, and confirm with molecular.
Or you can also do molecular typing of the species.
Yeah.
Okay. That's very important because the treatment will be directed to the species.
This one also knowledge science.
Okay.
Basically, all my case, knowledge science.
So common, the most common species. Wow, so they have actually now dominated the whole, sort of dominant species.
So case number 4, 48 years old, prolonged fever, mild anemia, thrombocytopenia.
All right. Yes. So this is another case. Somebody mentioned whether it is necessary to state the species. Obviously, it's important because recognizing the species, you have to inform the managing clinician because they have to tailor the treatment according to the species. As far as possible, we should actually make not only say it's malaria, but what is the species.
This is also Plasmodium knowledge case.
Okay. But one thing your slide actually quite shown is that if you see inclusion bodies in the red cell, then you have to heighten your suspicion whether you are dealing with malaria. And of course, that's now you trick us, the thalassemia major with Howard Jolly bodies, Somebody mentioned about looking for the schizon and the gametes. Obviously, if you can see them, you search for them, then it might help you. Like for example, falciparum have all these crescented shaped gametes, and then different species, the gametes are actually looks different. So all these examination will help towards determining what species you are dealing with, and you therefore can report accordingly. Yeah. Like for example, you make a diagnosis of Virex. You cannot simply just give chloroquine. You have to give additional treatment for the liver stage. Okay.
Okay, probably this is another one case, but I don't have the medical history.
Okay. Yeah. They all look similar. All your cases.
Yeah.
Obviously, all have
All knowledge side.
no side. Yeah. Okay. Yeah. Wow. Very good for us, lah. We hardly see these kind of cases in Peninsular Malaysia nowadays. Okay. Any more to show?
That's all, Prof.
Okay. Very good. Fantastic. Wow. Yeah. You managed to scan all this slide, or not?
No, I'm using camera.
You use camera. Oh, wonder whether your histo department got a scanner, right?
Yes.
Oh, wonder whether you can scan this slide. So useful for teaching purposes. Yeah.
Okay, Prof.
Okay, good. Yep. You have a very good collection of malaria slides. Wonderful. Thank you very much for sharing this with us. Yeah, long time haven't seen a malaria parasite in the blood film, especially for us that in city area, I hardly got any chance to see them. All right. Okay, so I think we got some comment. Yeah. All right, so we let's see whether any more comment from anybody. If not, I think we have a wonderful sessions with sharing from East Malaysia, particularly Sabah in this case. Yeah, and especially those malaria cases. Fantastic. All right. So that's all for today. So thanks again for Dr. Nasir for taking his time, also effort to trace all the slide and make the presentation. So thank you. Thank you very much. Really
Thank you, Prof.
fantastic effort. Bye-bye. Wow.